Ulcers are ulcerations of the mucous membrane or deeper structures of the GI tract. This commonly happens in the stomach, gastric ulcers, the duodenum ulcers. PUD refers to acid in our digestive tract that erodes the mucosal lining of the stomach, esophagus, and duodenum. If you remember, the cells that rapidly divide and produce are hair cells, mouth, our entire GI, nails, and bone marrow. The stomach has a natural protection against stomach acid or autodigestion by way of gastric mucosal barrier. The mucosa is renewed about every 3 days, which means it's continuously repairing itself, except in rare situations like third-degree burns, when the cells break down faster than the renewal rate. A PUD can occur. The most common cause of PUD disease is physical or emotional stress, high alcohol intake, smoking, chewing tobacco, regular use of pain medications, and H. pylori, which is a bacteria in the stomach of spiral shape. It is important to note that H. pylori can be transmitted by saliva or body fluid, also by food, water, or utensils. Stress-related mucosal disease is an acute ulcer that develops after major surgery. It's believed that gastric mucosa occurs due to a brief loss of blood flow called ischemia, just like in the heart. And again, ischemia is due to decreased capillary blood flow as blood is shunted away from the GI tract, which means the blood flow bypasses the GI mucosa. When this happens, your body is trying to compensate due to the shock or hypotension. Decreased blood flow cause an imbalance between hyaluronic acid, pepsin, and other protective factors of the stomach mucosal barrier, mainly in the fundal portion, may cause superficial erosions that result in bleeding. Because of the possibility of developing a stress ulcer and the high morbidity rate, a nursing intervention we provide is to minute prophylactics to prevent this from happening, along with anti-secretory agents which inhibit or decrease gastric secretions, including H2 receptor blockers and protein pump inhibitors that decrease stomach acid. Manifestations. Both ulcers have similar symptoms, but they differ in time, degrees, and factors. The pain may be dull, burning, gnawing, persistent in the esophageal region. Subjective assessments. Pain associated with food intake, but does not wake the patient at night, or empty stomach. Nausea, weight loss, belching, distension, minor esophagus discomfort. All subjective symptoms intensify if perforation or obstruction occurs. Objectives. Observe for some signs and symptoms of complications of PUD. Hematemesis, vomiting blood that is bright red or coffee ground appearance. Also black tarry stool. Hemorrhage, bleeding that can quickly worsen in emergent situations if it erodes into the blood vessels. Surgery may be needed if the patient remains unstable after receiving blood over several hours. Perforation is when the ulcer crater penetrates the entire thickness of the wall of the stomach or duodenum, releasing air, gastric acid, pancreatic enzymes, bile into the perineal cavity, causing pain, emesis, fever, hypotension, and hematemesis. Gastric outlet obstruction is a blockage close to the pylorus, causing stenosis and dilation. It's caused by scarring and inflammation. These symptoms can be relieved by an NG aspiration of the stomach contents. Fiber optic endoscopy can detect both gastric and duodenum ulcers. This scopy provides a direct visual of the entire esophagus and gastric and duodenum mucosa. Patients are sedated but remain conscious. A local anesthetic in the throat is given to decrease the gag reflex and for pain. Remember, no fluids or food until the gag reflex returns. A non-invasive test is used to detect H. pylori. A patient drinks a solution containing carbon-13 and enriched urea, a non-invasive substance. If H. pylori is present, it breaks down the compound and releases carbon-13 dioxide. Within 30 minutes of drinking the solution, the patient exhales into a collection bag and the bag is analyzed. Finding of carbon-13 dioxide indicates H. pylori. Medical management. NG tubes remove gastric contents and blood. Scar tissues build up with repeated episodes causing obstructions. The primary treatment is to reduce signs and symptoms of PUD by decreasing or neutralizing normal gastric acidities with drugs. Drugs that are used are antacids to decrease your acid in your stomach. Histamines also decrease acid secretions by blocking histamines. Proton pump inhibitors prevent secretions of gastrin. Mucosal healing agents heal the ulcers. And anti-secretory and cytoprotective agents prevent against secretions and protect mucosa. Antibiotics are given for H. pylori. Flagyl and tetracycline are two of the most common. A 14-day supply of Helidac can be ordered for H. pylori. Treating H. pylori helps prevent reoccurrence. Nursing interventions. Education is key. We must teach our patients to eat smaller meals throughout the day. This will decrease gastric mobility activity. We need to remind them to stop smoking. Smoking delays healing and aggravates the mucosal lining and the duodenum. Educate your patient in avoiding caffeine and decaffeinated coffees. Also to avoid aspirins. Explain the need for a lifestyle change. When educating your patient, don't forget to include given a written or verbal instructions of the exact med dosage if they can be taken with or without food. Have a dietitian provide instructions on therapeutic diets. Explain that repeated episodes are not common. And make sure to listen for aggravating factors. Caution patients to avoid high fiber foods, sugars, salt, caffeine, milk, and alcohol. Explain the need to eat slowly. Include importance of rest and exercise, not to mention signs and symptoms of bleeding. Patients are sometimes afraid to move, so reposition them often without moving their tube placement. Check for kinks in their line and observe eyes and nose. Remember, most of these patients may be NPO, and they will be on intermittent or continuous suction. On intermittent suction, note the color and the amount of the secretions every 4 hours. No meals until the bowel sounds are active and return. Remember, their gag reflex may be delayed or absent. And when you do begin to feed them, start them on a clear diet. Some added information about their NG tube. Remember that this tube is a constant irritant to the nasopharynx, which requires care of the mouth and the nose. Ease your patient's fears and anxiety by explaining their procedures and what to expect. Don't forget to include the family and on the education. Doing this will greatly relieve anxiety and reduce fears. Educating your patient that they may not be able to chew, taste, swallow foods, and will be on a liquid diet will reduce anxiety when that time comes. You may also have a patient that is NPO, but they may still have ice. The purpose of an NG tube is to decompress, which is removing secretions, feeding, which is administering a liquid nutrition, compress, which is inflating a balloon to prevent internal GI hemorrhaging, and lavage. It's an irrigation of the stomach in cases of an active bleed, poisoning, gastric dilation, and an intestinal obstruction. Reoccurrences can happen within about 2 years. With H. pylori antibiotic treatment, reoccurrence drops to 20%. Make sure that your patient avoids any irritants and let them know that without treatment, the relapse rate is 75 to 95%. If any signs and symptoms occur, they should seek a medical assistant immediately.